أهلا بيكم. Today we will conclude the head and neck by studying the cranial nerves. So let's begin. The cranial nerves are 12 pairs of peripheral nerves, part of the peripheral nervous system. You know, the peripheral nervous system are the nerves emerging from the central nervous system, which is the brain, brainstem, and the spinal cord. And all of these nerves originate from the brainstem, except for the accessory, as we talked about before, that it arises from the upper cervical spinal roots, spinal segments, and enters the foramen magnum and counted as a cranial nerve. Because actually it is at the same line of the inferior branches, rootlets of the vagus nerve. We will see it now. Okay? The brainstem is composed of three parts: the midbrain and the pons, the medulla. This is the thalamus high up, taken in this section, especially the pulvinar part, the posterior part of the thalamus, taken with the midbrain. As you can see, this is the lateral surface of the brainstem, where the crus cerebri or cerebral peduncle is there. This is the cerebral peduncle, part of the midbrain, contains fibers to and from the cortex, especially the corticospinal and corticobulbar fibers. Okay, and this is the tectum of the midbrain, with the four colliculi, the superior colliculi and the inferior colliculi. As you can see, the inferior colliculi connected by a brachium to the what's so-called the medial geniculate body. This is part of the auditory pathway, by the way, while the lateral geniculate body and the superior colliculus is part of the visual pathway. So these are for visual and hearing related coordinative movements or reflexes. Now, we mentioned the cerebral peduncle. It's the peduncle, the fibers that connect the brainstem to the cortex high above. Now, there are groups of fibers that connect the brainstem to the cerebellar hemispheres. These are called the cerebellar peduncles. This is the superior cerebellar peduncle connecting the midbrain to the cerebellum, or called the brachium conjunctivum. This is the middle cerebellar peduncle. It's huge, and it's obvious it's part of the pons that connects both cerebellar hemispheres together. And this is the inferior cerebellar peduncle that comes from the medulla oblongata and enters the cerebellum. So we have three cerebellar peduncles on each side, three pairs, okay? And here in the medulla, you can see the origin, by the way, of the trigeminal nerve from the ventral aspect of the pons, sensory and motor roots of the trigeminal. Here in the medulla, I told you before that the upper part is called the open medulla, which is part of the fourth ventricle, and the lower part is the closed medulla. But anyway, on the lateral surface, you will see the inferior cerebellar peduncle, this one, then a sulcus, then an olive, then another sulcus, then the pyramid at the front. Now, the pyramid is the corticospinal tract descending after crossing, forming the pyramidal tract, going to the rest of the body. Okay? Between the pyramid and the olive is the anterolateral sulcus, as you can see here. And posterior to the olive, between the olive and the inferior cerebellar peduncle, there is the posterolateral sulcus. Why am I telling you this? Because from the anterolateral sulcus comes the rootlets of the hypoglossal nerve. Means it's emerges from the medulla between the olive and pyramid. This is important in multiple choice questions. And the rest of the nerves, the 9, 10, and 11, emerge from the posterolateral sulcus between the olive and the inferior cerebellar peduncle. Okay, so now you know the origin of the lower four cranial nerves from 9 through 12. As you can see here, in this area is called the Cerebellopontine angle because the cerebellum is back there. It has actually three nerves emerging from the brainstem. The medial one is the facial, then an intermediate one called the nervus intermedius, then the nerve, the eighth, which is the vestibular nerve, all coming from the area of the Cerebellopontine angle, which is a common site for astrocytomas, brain kind of brain tumors, and you can detect its symptoms from the pressures on these two nerves. I mean, if there's a degree of facial paralysis, for example, at one side, if there's a tinnitus, which is hyperstimulation because of the pressure on the vestibular nerve, it's like a ringing deep sound inside the head, the tinnitus. So you can apply your anatomy information to help you in assessing your diagnosis of intracranial lesions. Okay, this is 7 and 8. 6 from the front between the pons and the medulla. Then comes 5 on the pons. Then 3 and 4 and 2 and 1 at the top. To study the cranial nerves, you should also study the functional components of these nerves. Functional components means terms used to describe the kind of impulses these fibers are conducting or conveying. We have a category general somatic afferent, means general sensation, pain, touch, and temperature. From the body wall. Body wall, I mean skin, muscle, bones, and joints. The stimulus for these kinds of sensations is the same all over the body wall. I mean touch and pain. Pain comes from chemical or thermal or mechanical stimuli, and temperature. This is the thermal stimulation, for example. But you can get the same sensations from the viscera. This is called general visceral afferents, but the stimuli will be different. For example, for the pain from viscera, it comes from distension or spasm or infarction. Infarction means to cut off the blood supply on a certain area of any viscus. Okay, this is called the general visceral afferent. The famous example, of course, are the labor pains. It's because of dilation of the cervix. The cervix by itself is not sensitive to touch or mechanical stimuli or even thermal stimuli. You know what I mean now? So they need different types of fibers but carry the same sensations, but from the viscera. It's called general visceral afferent. Special afferents or special visceral afferents, sensations, the fibers carry sensations, but they're called the special senses, like the smell, taste, vision, hearing, and balance. Okay, all these are classified as special afferents. General somatic efferents means the motor to ordinary, regularly developed muscles from mesoderm, from muscle chunks, voluntary muscles, skeletal muscles, general somatic efferent, like any nerve going to any muscle in the body. General visceral efferent, it's the same motor impulses, but to smooth muscle, means to the heart, to the GIT, to the blood vessels. Okay, all these are called the general visceral efferent. Branchimeric efferent, or special visceral efferent, as the old name indicates, it's motor to motor impulses, but to muscles derived from the pharyngeal arches, the branchimeric arches we talked about. And remember the innervation of the arches? We said it's 5 arches because the sixth, they are numbered from 1 to 6, but the 5th disappeared and it's 5, right? 5, 7, 9, 10, 10. 10, 10, the superior laryngeal, and the other 10 is recurrent laryngeal. And some people, by the way, consider the fibers in the recurrent laryngeal belong to the 11th cranial nerve, which is the accessory, distributed through the vagus. So whatever it may be, but the distribution is the same. So this is the functional components of the cranial nerves. It's important topic, and you must know it and understand it. Let's proceed with, run over the an overview or a kind of recall information about the cranial nerves we studied. The olfactory nerve, remember the receptors are in the roof of the nasal cavity in the olfactory mucosa, and gave filaments that relayed in the olfactory bulb, and from the bulb there's an olfactory tract that lies in the olfactory sulcus next to the gyrus rectus. Then it divides into medial and lateral stria to its olfactory cortex. This is the story of the olfactory nerve, nerve number 1. Number 2 is the optic nerve, and by the way, they are numbered according to their attachment on the inferior surface of the brain or the brainstem, okay, from the front backwards. Number 2 is the optic nerve, and you see here the left and right optic nerves decussating. It's not all the fibers that decussate, only the fibers coming from the nasal retinae, the medial half of the sphere of the eyeball retina. It receives the peripheral field. Be careful. The nasal retinae, the medial retina, receives the peripheral field because the light travels in straight lines, right? And the lateral retina receives the medial field. Okay? Now, what crosses here the fibers from the nasal retinae, from the medial retina that receives the peripheral field, cross to the opposite side to form the optic tract, and on its way it relays in the superior colliculus. As I told you before, it's involved in visual reflexes, and then through optic radiation to the cerebral cortex, which is the occipital cortex. We've studied it in the last lecture. The third one is the oculomotor nerve, and the cranial nerve nuclei in the midbrain. It has motor nuclei for the different muscles it supplies in the eye, except of course for the lateral rectus and superior oblique, because supplied by different nerves. And it has a parasympathetic element, right, component, Edinger-Westphal nucleus. It conveys preganglionic parasympathetic, for the ciliary ganglion we talked about. Okay, so remember 3 carries parasympathetic. The cranial nerves that carry parasympathetic are 3, 7, 9, and 10. Okay, 3, 7, 9, and 10. Oculomotor, facial, glossopharyngeal, and vagus. Remember the oculomotor divided into superior and inferior divisions before entering the superior orbital fissure, right? And the ciliary ganglion is hanging from the nerve to inferior oblique branch of the inferior division of the oculomotor nerve. It carries, of course, the optic nerve carries special afferents. The olfactory nerve carries special afferents. Oculomotor is motor to skeletal muscles, the orbital muscles. So it's general somatic efferent fibers, and contains also parasympathetic, which we said it's general visceral efferent fibers. The trochlear nerve, remember that it's the only nerve that emerges from the back of the brainstem. It's a crossed nerve, means going to the opposite superior oblique. And it passes between the at front between the posterior cerebral and superior cerebellar arteries, the same like oculomotor nerve passing between these two arteries, the terminal branches of the basilar artery. Remember when we studied the blood supply of the brain, and forwards through the cavernous sinus and then superior orbital fissure, and it's outside the cone of muscles, remember that, and it supplies the superior oblique, as you can see here, okay, from the superior surface. Okay, so it's pure general somatic efferent fibers, only motor fibers to one muscle. The trigeminal is the huge nerve that carries sensations from the head, actually. Carries general somatic afferents, and remember the motor component of the trigeminal that runs with the mandibular to supply muscles of mastication, and tensor tympani. Remember that? Tensor palati and tensor tympani. These are muscles derived from the from the first pharyngeal arch, so they get branchiomeric efferent fibers through the trigeminal nerve. And remember that it arose from the pons by two roots, a lateral sensory and medial motor root. The motor root remains separated until fused with the united with the mandibular division after emerging from the foramen ovale. Remember that this is the motor root. It's separate than the sensory. The sensory expands into the trigeminal ganglion, Gasserian ganglion it's called, that gives rise to the famous ophthalmic, maxillary, and mandibular divisions. And we studied these nerves, individual nerves in situ, right, with their branches. This is the trigeminal nerve. The ophthalmic nerve, as you can recall now, it's divided into three main branches: lacrimal, frontal, that divides into supraorbital and supratrochlear, and nasociliary, which is not this one. Don't get confused. It's a nerve inside the cone of muscles. These are outside the cone of muscles. This is the nasociliary nerve, the last of the branches of the ophthalmic. And you can recall how it ended by supplying the dorsum of nose and becoming infratrochlear, right? This is the nasociliary nerve. This is the divisions of the ophthalmic. The maxillary, of course, all of you remember the branches we studied in the pterygopalatine fossa, the direct branches and the branches through the ganglia. We discussed all this. And the mandibular division, which came out of the foramen ovale, and this is the maxillary from foramen rotundum, here from foramen ovale, with the motor root separate and then united with the with it after the foramen. And remember what else goes into through the foramen? Exactly, the lesser petrosal nerve to relay in the optic nerve, and the accessory meningeal artery. This lecture actually is a review on all the nerves we studied. It will help you recall. Okay, abducens nerve, the number 6, or it's called abducens sometimes, abducens nerve, arises from the ventral aspect of the brainstem, between the pons and medulla in the middle, and it enters the cavernous sinus in the floor, right lateral to the internal carotid artery, and enters the superior orbital fissure to supply the lateral rectus, as you can see here. It's inside the cone of muscles, of course. We now learned that any nerve that supplies these muscles supplied from the ocular surface, so it has to be inside the cone of muscles, from the inside, not from the outside, like the trochlear, for example. The facial nerve. The facial nerve, we've learned its story inside the inner ear, and how it exited from the middle ear, how it gave branches, in the middle ear, the nerve to stapedius, and the chorda tympani, and it exited through the stylomastoid foramen, how it supplied the stylohyoid and posterior of digastric, and the occipitalis part by posterior auricular branch, and then entered into the substance of the parotid, dividing into the temporal, zygomatic, buccal, marginal, mandibular, and cervical branches. And by now, you should be able to distinguish site of injury of the nerve because you know the sequence of branches. So central lesions like the ones at the Cerebellopontine angle where the nerve emerges, it's before all its branches, so you will get the patient will get paralysis at the same time and hyperacusis because it will not supply the stapedius muscle and so forth. If distal lesions like at the common site, which is emergence from the stylomastoid foramen, especially in babies born with forceps, faulty forceps technique crushes the nerve, which is rather superficial in the newly born because the mastoid isn't big enough. So only the patient gets what it only gets is the Bell's palsy, the facial paralysis at the same side. Okay, use these info to localize or to come out with an idea about the site of the lesion. The eighth nerve is the vestibular cochlear nerve, and we discussed this as the cochlear nerve coming out of the organ of Corti, the organ of hearing, which has cells that gets compressed against the tectorial membrane, and that was the point of transduction from mechanical stimulation to electrical stimulation. And it has a ganglia too, the spiral ganglia. The vestibular nerve has vestibular ganglia, but it's connected to the organ of balance, which is the utricle saccule and the three semicircular canals. And remember the receptors in the utricle and saccule is called the macula, and in the semicircular canals it's called the crista ampullaris. Remember this. Okay, and it's in the ampulla of each canal. And Y3, we discussed this before as to cover the balance in a whole, in a hemisphere, and because they are aligned with the other ear, we will be able to balance in a whole sphere. Okay, one complete sphere. The two nerves unite inside the substance of the petrous temporal bone and exit through the internal acoustic meatus and enters the brain in the brainstem in the cerebellopontine angle as well, lateral to the nervus intermedius. So it is liable to be injured in tumors at this area. Expresses itself with impaired balance and tinnitus, actually, or a kind of vertigo or nystagmus, okay, because of the impaired balance. The glossopharyngeal nerve, the ninth cranial nerve, remember it emerges from the jugular foramen, okay. This is the ninth cranial nerve, jugular foramen. It curves around the lower border of the stylopharyngeus. This is the stylopharyngeus, and the nerve expands to join the pharyngeal plexus, which is mainly made by the vagus. Okay, and it goes to the oropharynx. Remember the glossopharyngeal. It carried general visceral afferents because we talked about its carotid body and sinus branch, its sensation from the visceral organs, the carotid body and sinus that controls the oxygen tension and the pressure in the carotid arteries. It also carries general sensations from the posterior one-third of tongue, so GSA, general somatic afferents. It carries taste from the posterior one-third and the valate papillae, so special afferents. And it carries autonomic parasympathetic, remember, the glossopharyngeal to the parotid through its lesser petrosal nerve. This is the lesser petrosal nerve, and synapsing in the otic ganglion, and from the otic ganglion, postganglionic will go through auriculotemporal to the parotid gland. Okay, and carries branchiomeric efferent, because do not forget the stylopharyngeus, the single muscle it supplies. So it's muscle derived from the third pharyngeal arch, which takes from the ninth cranial nerve. Okay. Also, do not forget its tympanic branch, that with the strange story that after the nerve emerges from the jugular foramen, it branches and goes back again to the skull, and it's all caniculus to the middle ear, and emerges from the floor of the middle ear, as we saw before, and spreads its network over the promontory, which is over the basal turn of the internal ear, and supplies the mucosa of the middle ear, the mastoidal cells, and the tube, pharyngotympanic tube. Remember those? Those are sensory fibers that represent the GSA that the glossopharyngeal carries through the tympanic branch, and the tympanic branch also carries the fibers that will give rise to the lesser petrosal, which are the preganglionic parasympathetic to the parotid gland. Okay, a good review of the nerve. The vagus nerve, this is the vagus nerve, descending, and you know the story till it reaches the root of neck and enters the thorax, thoracic inlet. It gives off the pharyngeal plexus that supplies motor to the muscles, and carries sensation from the larynx, laryngopharynx. So these are general somatic afferents. Carries information from the aortic body and chemoreceptors, and same receptors, baroreceptors. In the baroreceptors means they measure pressure in the aortic arch. So these are sensations from viscera, general visceral afferents. Receives taste from the epiglottis and pharynx, so special afferents. Of course, it's a major parasympathetic nerve, so general visceral efferent, and branchiomeric efferents to muscles of the palate and palatoglossus fibers. So do not learn these functional fibers by heart. Just if you understand the branches of the nerve and the targets it supplies, you will be able to come out with the term for this. Do not waste your time and try to learn them by heart. No, try to understand them, and you will come out with these fibers. And also, if you know them, they will help you come out with the targets if you happen to forget one of the targets. Okay. So this is the vagus nerve. Remember, it distributes the cranial nerve, cranial accessory with it, and some people say it's in the form of the recurrent laryngeal nerve, the motor to the pharynx, and sensation below the vocal cords. Okay, the accessory nerve, back to this nerve again, with the unusual story of arising from cervical spinal cord segments, entering the skull through foramen magnum and running with the cranial part, and then leaves it and goes out again through the jugular foramen. Remember this story, to supply the sternocleidomastoid and emerge from its posterior border. See, this is the nerve, which is rather superficial course, and ends in by supplying the anterior border of the trapezius. These two muscles are classified as of branchiomeric origin, so it carries branchiomeric efferent fibers to the sternocleidomastoid and the trapezius muscles. Okay, there was a debate about whether there was interchanging of fibers in the root, in the intracranial root, or not with the cranial rootlets. But anyway, this is what happens. But with my experience, I saw an accessory. I dissected an accessory nerve that directly comes out from the vertebrae, did not go inside the skull and out again. There was a paper about that. Okay. This is about the accessory spinal accessory nerve. Okay. The last nerve is the hypoglossal nerve, and it arises from the nerve that arises from the medulla, but not in series with the 9, 10, 11th. No, it's in front of the olive, between the olive and pyramid. The hypoglossal nerve, it knows its target, the muscles of the tongue. See, this is the lingual nerve here, and this is the hypoglossal nerve, and we studied its course, how it's on the lateral surface of the hyoglossus muscle, accompanied by venae comitantis, or the deep lingual vein, right? As it goes to the inside, deep to mylohyoid, to supply the muscles of the tongue, except the palatoglossus, of course, which is supplied by the vagus. Okay, and we talked about the lesions in the hypoglossal nerve, like if you affected one side, the tongue will protrude and points to that side. And we explained how, because of the action of the genioglossus muscle. Okay, so the hypoglossal nerve ends the series of the head and neck. I hope you got all the benefit from this series, and we'll continue the rest of the body soon. Okay, thank you very much for watching.